Interpretation of laboratory results, Immunology Serology, Unit 3, Part 1. This unit is about the immune system, and we have to start with a definition of immunology. Immunology is the study of the immune system, and the function of the immune system is to recognize self-antigens from non-self-antigens, and once that recognition has been made, to make antibodies against non-self-antigens. What is an antigen? An antigen can be any substance, any molecule, any cell, or any organism that can stimulate the production of immunoglobulins or antibodies. We have self-antigens that makes us unique, that makes us us, and there are non-self antigens that are anything that does not belong to self. Organisms, bacteria, funguses, parasite. You know how we have normal flora, organisms that are bacteria that is in our intestine, in our gut, that is part of us, that is self, and that is there to protect us. Well, not all bacteria is bad, not all bacteria is non-self, but a lot of bacteria is non-self, and it has to be, when recognized by the immune system, it will be targeted to be destroyed by the immunoglobulins that are made against those organisms, whatever the organism is. When the immune system fails to recognize the self markers, when it fails to recognize self, then we end up with an autoimmune disorder. An example would be rheumatoid arthritis. In people with rheumatoid arthritis, the antibodies that are made by the body are antibodies against tissues that belong to the patient, tissue found or cells found in the joints. So that's why there's no cure, because it is the body that has failed, the immune system of the patient that has failed to recognize self. On the right side of slide number 2, we have a little bit more information about self and non-self antigens, and then the antibodies. And if you look at the shape of the antibody, they look like a Y. It's just right there. They are different parts to that structure of the immunoglobulin that work very specifically against specific antigens. Slide number 3, it tells us, it goes a bit more into detail about how it is that the body recognizes self from non-self. And that has to do with a major histocompatibility complex antigens or markers. Those markers are found on pretty much every cell in our body. We have different types. There are 3 different types of major histocompatibility complex antigens or markers, 1, 2, and 3, and they have slightly different functions. But it's just so that you know, there is this big umbrella. This a very general term, encompasses all the different markers that makes us, or that are in our cells, to make us unique, to make us self. In that way, the presence of those markers is what triggers the immune system. So when the immune system, the immunoglobulins and the phagocytic cells and the complement proteins and the interferon, all these components of the immune system, when they encounter a cell, they see these markers, and they should be able to recognize it. Oh, this is self, this is me, this is part of this body. Oh no, this is non-self, this is foreign, thus I have to destroy it. Slide number gives us a very broad example of how the immune system works, the main components of the immune system, and we have the first line of defense that includes physical and chemical barriers, intact skin being one of them, acidity of the skin, the ears, hair, all those components of the first line of defense that are considered innate. Innate means that we're born with them, that they are natural, and they have no memory. The second line of defense is nonspecific, does not have memory, but it contains cellular components and chemical or humoral components. Humoral also means serum. It's an old term for serum. So these are chemical components that are found in serum. So we have the cellular components of the second line of defense that include the phagocytic cells, and the phagocytic cells include the neutrophils, monocytes, eosinophils, and basophils. Then we have the chemical or humoral components of the second line of defense that include specialized proteins, complement proteins, and interferon proteins. And there's a lot of cytokines that are also involved there. And then we have the third line of defense, and the third line of defense is characterized by having memory and by being very specific. And it is acquired. We're not born with it. We have to, it has to develop with age, with the exposure to different organisms. We get that third line of defense. So slide number 5 goes into more detail about some of the components, some of characteristics of the first line of defense, and things that are involved in the first line of defense. We have the tears, the skin, intact skin. We have the large intestine, not just the large intestine, all the intestine, small intestine and large intestine. But the large intestine has a lot of normal flora, a lot of microbiome bacteria. And then we have the saliva, we have the respiratory, in the respiratory tract, we have the mucus, and we have the hair that prevents organisms from going in. In the stomach, we have the high acidity of the stomach that kills the organisms. The bladder, when we urinate, we do not urinate in drops. We urinate in a flush. And the flushing action when we urinate is there so that we can flush out all the organisms that might gather around the genital area, where it's usually warm and moist, ideal environment for bacteria. So when we urinate, we flush those out so that they don't go into the body and cause infections. The next slide is the second line of defense. And like I had mentioned, we had part of the second line of defense is the cellular components and the chemical or humoral components. Second line of defense, just like the first line of defense, is non-specific and it has no memory. The cells will always do their job, but they are not going to remember whether they had done that before or not. There are no memory cells here. And those, again, the cells involved in the second line of defense are the phagocytic cells and some natural killer cells. These lymphocytes that are different than the lymphocytes involved in the third line of defense. The natural killer cells, their function is to kill. They do not wait to identify specific components of the cell. If they just see the cell for like a cancer cell that looks very different, they are going to kill that cell. So we have the phagocytic cells and the natural killer cells. The phagocytic cells, again, are the neutrophils, monocytes in blood, but they turn into macrophages in tissues, eosinophils, and basophils. Then the humoral components, or the serum chemical components that are part of the second line of defense, include complement proteins, and this we have a whole bunch of them. It's over 30 proteins that are produced mainly in the liver that have a very specific job, and their function is to break or to lyse cells, specifically bacterial cells. They will attach to the bacterial cells, and they are going to make a hole in the cell wall of the bacteria, and they will lyse, they will break. They also are are involved in enhancing the phagocytic process of the white blood cells, and they stimulate inflammation. One thing about inflammation that we need to make sure that we understand is that the inflammatory process that happens between when the first line of defense has been broken and the second line of defense gets activated, is that this inflammatory process has to be acute. It has to be rapid, it has to be very fast, it has to be self-limiting. We don't want to have inflammation all over the body. It only has to be at the site of injury, and it has to be for a short period of time. We do not want the inflammation to last weeks or months or years because it leads to tissue damage. So we want to be short and to the point and very, very specific. The other chemical or humoral components of the second line of defense are called interferon proteins. And what they do is they interfere or they slow down the viral reproduction. So they prevent the viruses from reproducing once they get access into our body. So it's again, these are humoral or chemical components of the second line of defense. And just like the phagocytic cells, they are non-specific and have no memory. Slide number 7 tells us a little bit of information about the third line of defense, and something very different about the third line of defense is that it has memory, it's acquired, and is very specific. And this is when immunoglobulins or antibodies are going to be made against specific antigens. The organs, the cells that are involved in the third line of defense are the lymphocytes. And the chemical or humoral components that are part of the third line of defense are the immunoglobulins or antibodies. So the cellular components, lymphocytes, we have two different categories of lymphocytes, the T lymphocytes and the B lymphocytes. Both of them come from the same stem cell in the bone marrow, but they mature. They become specialized cells in different organs. If those very immature lymphocytes migrate to the thymus and mature in the thymus, then they will become T lymphocytes. If they stay in the bone marrow to mature and get all their specialty components, if you want to call it that, then they will become B lymphocytes. The T lymphocytes get their information about the non-self antigen, and then they give it to the B lymphocytes, and the B lymphocytes produce the immunoglobulins, the specialized proteins that have very specific functions. And we have five different types of immunoglobulins or antibodies, and we have IgD, IgA, IgM, IgE, and IgD. And an acronym to remember them would be GAMED. That's why I put them in this order, even though they are not in order of quantity here. In the next slide, we'll have it by quantity. And these are characteristic of immunoglobulins or the antibodies. And part of homework includes that you write down some of these characteristics. So make sure that you understand what the importance of each one of them. IgG has the highest concentration in serum, is the most abundant. It is also known as gamma globulin. It is the one that is associated with immunity or with the chronic infection, but mainly immunity. We know that if a person has IgG antibodies, it's because they now have memory. The lymphocytes have memory and have this information, and they have immunoglobulins in there to kill the organism if it ever comes again. And one other thing that is very important about IgGs is that they are very small enough to cross the placenta. So the immunity of the baby, of the fetus in the newborn, the immunity that they have comes from the mother. And because not until they get exposed to the environment are they going to very little by little little by little, produce the immunoglobulins against the different organisms that surround them. But the most immunity that babies or newborns have come from the mother because of the presence of IgG. There's another one that is coming up that is also present, and is from mother to babies. IgM is the second most abundant in the body, and it is the largest immunoglobulin. It is huge compared to the other ones. And one thing that is very important about IgM, it is the first antibody to be produced whenever the patient, or whatever, anybody, any of us, is exposed to an antigen. And whenever we find IgM antibodies, we know that the patient just had recent exposure, or that is in an acute infectious process. It's a recent exposure to the antigen. Then we have IgA. IgA is also called secretory antibody because it can be found in different body fluids. It can be found in secretions such as tears, saliva, and breast milk. So mothers that are breastfeeding do give extra immunity to their newborns through this IgA. So we can also find IgEs. IgEs are involved in allergic reactions, and they increase in number, a huge increase in number whenever there is a parasitic infection. Then we have IgD, and IgD is found in the smallest amount. They actually do not know the job that IgDs have. They just know that it's found on the surface of some other lymphocytes, but they don't know how they help the lymphocytes. They have to have a job since they are there. The scientists have not found out the specific job of IgD. Then we have slide number 9, and slide number 9 is very important. This shows us, on the graph on the right, we have a schematic of how the body reacts to the presence of an antigen, and how it looks in immunoglobulins, or antibody response. I'm going to use the COVID-19 as an example. You have heard, I'm pretty sure you have heard, that it is it's not necessarily a new virus, but it is a new virus that has not been found in humans before, right? So humans have not been exposed to this COVID-19 virus. It was found in animals, and it has a whole history. I think there's a show on TV that gives you the whole history, but for us humans, we have never seen it again. So what happens when we first encounter that virus, when it first enters our body, when it breaks the first line of defense? We're going to have the phagocytic cells, we're going to have the interferon, all these cytokines working to try to kill the virus. But because it's foreign enough, then it's going to be presented to the T lymphocytes, so that the T lymphocytes gather all the statistic information. This is a virus that looks like this, that is like that, it's a DNA virus, it's an RNA virus, all the specific characteristics of the virus will be gathered by the T lymphocytes. And then once the T lymphocytes have gathered all that information, they are going to tell the B lymphocytes, okay, B lymphocytes, now make an antibody specific to this organism. And how is it going to happen? Well, first the immune system is going to make very specific antibodies against COVID-19. And the first type of immunoglobulin or antibody will be IgM type. That is a huge molecule. It has 5 different structures. It's going to be the first one to be made. And then it's going to switch over and start making anti-COVID antibodies, IgG. So that's it. And then IgG will stay there. The IgG will be right there for a long time. There's going to be a decline, but it's going to stay there. if we ever encounter that same virus again, if we are ever exposed to COVID-19 again, then our body is going to go through an anamnestic response or a secondary immunoglobulin response, and it's going to react right away. There's not going to be a lag time. Our body is not going to have to wait for all these processes, all this analysis to happen by the different cells to make immunoglobulins. The memory cells are going to say, yes, I have the statistics, so I have all the stats for this virus. I'm going to make a lot of immunoglobulins, and I'm going to make it so that it is killed right away, so that I can destroy this antigen right away. That's why they are talking about the plasma of people that have been exposed to COVID-19 that have had the infection, that the plasma can be used to treat patients that are going through the infection, patients that are in ICU and that are in ventilators, just to help them fight off that infection, because they have those immunoglobulins present, and that will help the patient that has the acute infection, boost their immune system so that they can fight it off. So this is very very important slide. This is what happens in vaccines. When we receive a vaccine, we're first exposed to a very tiny, minute amount of very specific part of the antigen, whether the antigen is a bacteria or is a virus or any type of organism. Then our body is going to be exposed through the vaccine, right? They give it to us. We sometimes have fever. We feel a little under the weather. It hurts whenever we have the flu shot, right? They give us the flu shot and it hurts a little. And that is so that the body can start making immunoglobulins, because if we ever encounter that whatever organism they gave, if we ever encounter it again, then our body will respond in a very, very fast manner, and it will prevent us from actually getting sick. Slide number 10 moves over to serology. Serology is an older name, but it is still around, and it is considered sort of a branch of immunoglobulin in which we use the presence of antibodies and antigen and their interaction to diagnose a patient. So if we want to find if a patient has been exposed to an organism, we don't necessarily have to find the organism. We just have to look for the antibodies against that organism. If the antibodies are in the patient's plasma or serum, we know that the patient had contact, the patient had that organism in their bodies because their immune system was activated. It is very widely used for a lot of nasty diseases. And again, we can look for the antigen, the organism itself, or we can look for the antibodies in the patient's plasma or serum. And I wonder if I could see you right now, my question would be, what is the difference between plasma and serum? So plasma comes from blood that has been spun down, but it was collected in an anticoagulated tube, so it didn't clot. And serum is a liquid part of the blood that didn't come from an anticoagulated tube, so the specimen clotted, used all the coagulation factors, and now we have serum, right? Antibody titer gives us an idea of the amount or the concentration of the antibodies in the patient's blood, and it can tell us, depending on the cutoff value that we have, it can indicate whether a patient has immunity against that organism or is non-immune. Not just because you receive a vaccine doesn't mean that the patient has immunity. So if you are in the medical assisting program, you know that you're going to have proof of immunizations and titers, like the titer for the Hep B, Hepatitis B, the MMR titer, and the varicella titer. Yes, I receive all the shots. I have shot record and is right here, but that doesn't mean that you have immunity. A lot of students, we have a problem in our program because a lot of students believe that they have immunity against, especially against Hep B, and then they get their titer and they have no immunity, meaning they got the hepatitis B vaccine, and it's usually a series of three different shots, but their body is such a small amount that they give us that they sometimes is not enough to awaken to make the body produce immunoglobulins. So that's what the titers are for. Titers tells us an approximate concentration of antibody, of specific antibodies in the patient's specimen. Something to remember about viral infections, we need to remember that viruses require the host cells to reproduce. We need to remember that if we want to kill that virus, we have to do it in a way that doesn't harm the host cells a lot. They are going to be harmed because a lot of viruses are reproducing themselves within the cells, but they can, because they become part of the host cells, then they can become dormant, and then they can resurface later on in life. That's why the cold sores. You might have a cold sore, and then you get stressed, or you get sick, or your immune system drops, and you end up with another cold sore again. And herpes is very good at doing that. It remains dormant, but most viruses have the ability to become dormant. And there are viruses that are DNA and RNA. And again, we can find their presence, not so much because we find the virus itself, but because we can find the antibodies that the body makes against them. Now, the slides, the 12 to 20, they are examples of very specific disorders, just so that you can become familiarized with the testing of this of the patient specimens to diagnose, to find out whether they have been exposed to specific bacteria or to some viruses. And the first one that we have is infectious mononucleosis, also known as mono or the kissing disease. It is caused by the Epstein-Barr virus, and it is transmitted through saliva. So anytime you share saliva, either because of the droplet saliva when we're talking or sneezing, or through kissing, or sharing, glasses or bottles, or a drink, you share a drink, you're sharing a drink, and you drink from the same glass, and this person has the Epstein-Barr virus, then you might have it too. Signs and symptoms: patient will feel like flu-like they have the flu. It can be very mild, but there are some cases that are severe enough for the patients to require hospitalization. So it can be really bad too. They will show some inflammation of the lymph nodes in the neck. So the cervical lymphoadenopathy will be present. And in the CBC, if the patient has a CBC done, we're going to see very weird looking lymphocytes. We call them atypical lymphocytes. That, together with the signs and symptoms, is usually a giveaway. The doctor will know that the patient has mono. There's nothing they can give to the patient. It's a viral infection. They are going to recommend, a lot of rest, a lot of fluid, some medicine for fever if they are suffering fever, but they are just going to have to go through the whole process. One thing about Epstein-Barr virus is that it can lead to liver problems. Those complicated cases can affect the liver. So it is a virus that has been known to cause problems with the liver. So some liver enzymes might be elevated in the chemistry profile. And it is also known as an oncogenic virus. Oncogenic means that it can cause cancer. So it has been associated with nasopharyngeal carcinomas. So it is a sneaky virus. Can cause very mild infection, but it can be really, really bad. We can look for the presence of IgGs and IgMs, antibodies against Epstein-Barr virus, to confirm the presence or to diagnose a patient with infectious mono. Rubella, and this is part of the MMR. We get at least 2 doses of rubella vaccine, or because we want to prevent the German measles. It really, having the German measles is not a big deal. It is usually 3 days. You will feel a little under the weather, a little flu-like symptoms. It is transmitted through nasal and throat secretions, so, sneezing and coughing. But the problem is not so much with having German measles, but the problem is for pregnant women that happen to be exposed to the rubella virus, because this virus can cross placenta. So the mother might be okay. The mother may just feel a little under the weather, but if she's getting rubella, then if that virus crosses placenta, during fetal development, it can cause a lot of problems. It can cause what is known as congenital rubella, and it can lead to mental retardation, growth retardation, or even can cause a miscarriage. So it can be a nasty infection to get during pregnancies. Part of prenatal care includes the screening of rubella, just wanting to see if the mother already has immunity, and if not, anything that feels like might be rubella, like she would be exposed to rubella and that she might get the infection. Again, it's not so much because the mother to be, the pregnant woman, is going to get really sick. It's because of the problem with the fetus. How do we know if it is a recent infection or whether she has the immunoglobulins because of the vaccine? If it is a recent infection, she will have IgM antibodies against rubella. If it is because of immunity, she will have IgG antibodies against it. So IgM tells us that is a recent exposure. IgG tells us that is probably vaccination or past exposure. She was exposed to the organism either through vaccine or the actual exposure, but is no longer an ongoing infection. In newborns, when they are looking to see whether the baby was actually or the fetus was affected during gestation with a rubella virus, they will not look for IgG because the IgGs can come from the mother. IgGs can cross placenta, but if the newborn comes out positive for rubella antibodies, IgM, then that means that the baby got infected, that the fetus got the infection during gestation, and they will have to monitor the baby and see if there's anything that they can help, any developmental help that the baby might need. So rubella, again, IgG, past exposure or immunity, IgM type of immunoglobulin, recent or acute infection. And when we're talking about newborns, we know that the fetus was exposed to the organism because we find IgM in the fetus's plasma or serum. Then we have varicella, or the chickenpox. I had chickenpox when I was little, so it was not considered a big deal. Now we have to get, vaccine, and we want to be vaccinated because, I had chickenpox when I was little. That means that I'm getting up in age. I'm getting older. So as we age, we had chickenpox. That means that the virus can be dormant, and now we can have shingles. And they tell me that it's no fun having shingles because it's the same virus. And it's really not, for most patients, is really not a bad infection. But there are some, and there's a higher population than what we previously believed, that can end up with complications and even problems with brain function, problems with pulmonary and cardiovascular function. So it can become complicated. But when we're little, it's like, I come from a family of four. So the four of us had chickenpox pretty much at the same time. Poor mom. We were just cranky. So how do we know that a patient has chickenpox? Well, if they have IgM antibodies against chickenpox against varicella, so anti-varicella IgM antibodies, that means that the patient has the infection right now, has a recent exposure to the organism. But if they only find IgG antibody, so anti-varicella uh, IgG antibodies, then that means that they had past exposure or immunity. So again, this is the extension. If you understand this, the presence of IgM type of antibodies, and remember that the antibodies have to be specific, then that means recent exposure. IgG is immunity or past exposure to the organism. Then we have the hepatitis A, B, and C. Actually, there's more than that, but you only need to remember these ones. These ones are the ones that are most common. A is fecal oral, meaning we eat it from contaminated food or water. And we find anti-hepatitis A IgM type antibodies, then that means that the patient has an active hepatitis A case. If we find anti-hepatitis A IgG antibodies, that means that the patient was exposed to it before, past exposure or immunity. Hepatitis A is usually self-limiting, is you just get diarrhea, full-like symptoms, maybe jaundice, some bleeding of the skin. Depending, it can range from a mild to a severe case. Hepatitis B and C they are both transmitted through blood and body fluids. So any activity in which you share blood or body fluids can lead to infection with Hep B and Hep C. So what is the difference between? Well, hepatitis B is a more complex antibody. It's a DNA antibody, and it has a core, it has an envelope, and it has a surface. And we can find different antibodies to all those three components of the virus. And hepatitis C is an RNA virus. But even though hepatitis C is an RNA virus, and it really doesn't have a complex structure, hepatitis B, hepatitis C is most likely to lead to liver cancer, to become chronic and then lead to liver cancer. So we don't want that. So that's why it's really bad. Again, if they suspect a current infection or a recent infection, they are going to be looking for anti-hepatitis B or C IgM antibodies. If they are looking for past exposures or immunity, they are going to look for type IgG antibodies. HIV, you've heard a lot about HIV. We can look for the antigen or the antibodies, and a patient can be A positive without having AIDS. AIDS is when the patient already is presenting with diseases associated with having the infection, but a patient can be HIV positive and not have AIDS. Okay, so just so that we know. If anybody ever has an HIV test done and is positive, then it has to be confirmed. It has to. There are CDC guidelines that have to be followed, so they have to be confirmed by different methods, because you do not want to have an erroneous HIV diagnosis. The prognosis of the patient is followed through with blood specimens. They will look for the viral load. They will be looking to see whether the patient might have a co-infection. HIV is a virus that mutates very easily, and sometimes even a couple. If you have a couple and both of them are HIV positive, they might have slightly different strains, and they may end up with two different HIV infections, if you want to call it like that. The viruses that are HIV, they are HIV virus, both of them, but they are slightly different. So they can be resistant to medicine, or they can be just more problems to the patient. Then we have autoimmune disorders. And remember that we mentioned that when the immune system fails to recognize the markers that makes us self, then it can say, well, I do not recognize your pancreas, so I'm going to make antibodies against the cells in your pancreas. And we end up with type 1 diabetes. Or I don't recognize the cells in your intestine, big cells in your intestine, so I'm going to make antibodies against those cells. And we might end up with Crohn's disease. So it's just when the immune system fails to recognize self. And one of the very first tests that is ordered whenever a patient shows signs and symptoms of autoimmune disorder, of the patient needs to be screened to see whether it's an autoimmune disorder. One of the very first tests is the anti-nuclear antibody test, the ANA test. And it is the most common screening test for autoimmune disorders. As you can see on the picture on the right, there are different patterns of reaction. It is usually done through fluorescent testing, and depending on titer and pattern of fluorescence is the disease association. So the results have to be interpreted by a specialist. Then we have lupus, systemic lupus erythematous. It is an autoimmune disorder. And in this disease, the patient can actually produce autoantibodies against a lot of different organs. As you can see in the picture on the right, there can be antibodies against the patient's kidneys, the lungs, the skin, the heart. I mean, it can be systemic. It can be really bad. They look for the ANA. The ANA titer would have to be 1 to 160 in a very specific pattern of fluorescence. There are a lot of very specific. Once they know that they are dealing with lupus, they can refine their testing. So there are other tests that can be done. They can look for DNA tests. So we're not just looking at antibodies against the cells themselves, but antibodies against the specific nucleus of each tissue. So it can be very detailed. Then we have the example of rheumatoid arthritis. As you can see in the picture, it can hurt, it can attack. These antibodies will attack all your joints. And the cause is unknown, but there is a genetic predisposition, and it is also more common in females than in men, about 3 to 1. So that's bad for us ladies. There is a lot of inflammation in the joints, but as the disease progresses, as the antibodies, fail to recognize self, those antibodies can also start affecting other tissue, such as the lungs or the kidneys or the eyes. So it can be really bad. And how do we diagnose the rheumatoid arthritis? The doctor will order an ANA, and they are going to be looking for a very specific fluorescence pattern, and they want to have they're looking for a high titer of that antibody in there. Other examples of autoimmune disorders include inflammatory bowel disease, multiple sclerosis, Guillain-Barré syndrome, Hashimoto's thyroiditis, very common in women. Graves' disease, again, also is both of them, Hashimoto and Graves, have to do with the thyroid. So both of them can lead to completely different signs and symptoms, but can affect a patient's health. So I hope you have enjoyed immunology. There's more to it than this, guys. There are specialists, there are doctors that spend years and years and years studying how the body fights off and protects itself. So it is a very complex and very deep topic to explore. But I hope this gives you an idea of what we're talking about, or how the lab is involved in assessing the body's response to the presence of self or non-self.